This video will demonstrate the physical exam flow for a knee exam. This will cover some of the basics, and the knee gets pretty complex, so we might do some extra and some specialized tests, but if we do, we'll call that out as we go. In general, we would assume that you could follow along with this basic template and be able to chart the negatives as we go. Alright, so to start out, I'm going to assess a little bit for range of motion, but also for crepitation of the knee. So I have my hand here. I'm going to grab his lower leg. Go ahead and relax. And basically I'm just moving here. I'm noticing that there's no limit in knee extension. Knee flexion we don't really fully evaluate in this position, so we're just commenting on no restrictions in knee extension. Now with my hand here, I'm assessing for crepitus. If I don't call it out, please mark no crepitus. Oftentimes people with knee pain, they will have crepitus though. So I'm assessing for it. There is no crepitation. The next thing that I'm going to do is assess for stability of the knee. Similar to the elbow, we're going to assess valgus and varus. What's a little dissimilar to the elbow is we're also going to assess for anterior and posterior drawer to assess the ACL and PCL stability. So I'll explain those in a little more detail as we get into it. But to start out, I'm just going to bring his knee up to here. Go ahead and relax it for me and just let me do the work. Great. So I'm applying pressure from his lateral aspect, pushing medially, gapping in here. This is called valgus. So I'm applying valgus stress, stressing the medial collateral complex and ligaments, and that is stable. Next, I am pushing from medial to lateral. This is varus stressing. And again, let me do the work. Great. That's nice and stable. Okay, so that would be MCL and LCL are stable on exam. Next, we'll do the anterior drawer. So with that, the name is pretty self-explanatory. The clinician will grab the proximal tibia and pull anteriorly towards themselves. And then in the same motion, so I'm pulling anterior and assessing the end range there. I might be feeling a little bit of laxity there, but I don't want to scare Rob. So,
it's there.
Alright, so ACL or anterior drawer is positive. Now for the PCL, so I'm pulling, again, pulling, and now that I'm going to push back, and I'm going to go back more than normal, and that is the posterior drawer. And the PCL feels more stable than the ACL. So I'm going to say ACL is positive, LCL, MCL, and PCL negative and stable. Another test for ACL stability is called Lockman's. So after we do the anterior drawer, we'll often move to do Lockman's, and we'll just kind of bring him up here. And what gives Lockman's away is the clinician will have their hands on both sides of the joint. So we'll be at the femur and we'll be here at the tibia. And basically we're checking for translation there. And there, yeah. His ACL is definitely lax. So positive Lockman's. So now, while we're here,
We put some PRP in that ACL pretty soon.
Now that we're here, we're going to do some tests for the patella. And in the IMS flow, there's for the knee, there's an actual subcategory of patellar tests. So here what we're doing, his knee is extended. I'm going to palpate around the patella, just see if there's any tenderness there. No. I'm also going to move the patella around to make sure it's mobile. And this test is called the patellar, well, there's many names for it, but really what I'm assessing for is called patellar grind. and I'm not getting any patella grind. So that's good. Next is called patellar apprehension. So the clinician will basically brace the patella, push down on the quadriceps tendon, and what I'm going to do, I'm going to ask Rob, nice and slowly, can you lift your heel up off my leg? Great. And what happens is when he does that, it engages the quadriceps and it pulls the patella. So he didn't have any apprehension with that. He just did it, no problem. Patients that have a positive test, when they lift up, they'll stop. They won't go any further, and that's a positive patellar apprehension. While we're here, I'm going to palpate the posterior aspect of the knee. This area is called the Popliteal Fossa, and common things to find here would be a Baker's cyst, popliteal fullness. There can be some other findings, but we're just going to palpate for fullness. I'm not feeling any fullness. I'm not feeling any cyst. All right, next we're going to go ahead and flex the knee again. Now I'm going to palpate the joint line. So this area is the medial joint line, and what I'm going to do is get over here. Great. Any tenderness here?
Not really.
So as I slide here, I'm starting more anterior, moving lateral, more medial, and posterior, and I'm following the joint line. And what lives in the joint line? Well, that's where the meniscus lives. Okay, so I'm basically right on top of it. So in this exam, he's non-tender to the medial joint line. Now, just as when we're evaluating knees, shoulders, ankles, wrists, laterality is important. Laterality is important here in the sense that I'm examining his right knee, but also in the fact that I'm examining the medial joint line. And then I'm going to examine the lateral joint line. So keep track of medial and lateral. If I'm concerned, I might palpate. So here I was along the joint line, and you'll be able to see that pretty clearly because the clinician will follow their thumb along that. If I'm a little above that, here I'm on the medial femoral condyle, and oftentimes people with pretty severe arthritis or some sort of acute osteochondral defect, they may have tenderness of the bone itself. So I'm assessing for that here. And in IMS charting template, it'll have a portion for you to indicate whether the tenderness was on the joint line, the femur, or the tibia. Okay, so let's keep track of that appropriately. And if the clinician palpates those areas, mark them, and they're not positive, mark them as negative and that they were assessed. For the lateral joint line, I'm going to examine on this knee. So yeah, let's turn a little bit there. So I'm going to, again, just find the joint. Go ahead and relax here for me, please. Yeah. Good. So here, following the joint line, any tenderness there, so non-tender there. Here I'm on the tibial plateau, no tenderness there. Here I'm on the femoral condyle, no tenderness there. If patients are complaining of anterior knee pain, we'll do a more specific exam for the patellar ligament or tendon, the quadriceps tendon. Those are also going to be examined in great detail using the ultrasound, so we'll kind of rely on that more than our palpation. The last test for the knee is called McMurray's. In this test, you'll be able to recognize it pretty quickly. So what I'm going to do is I'm going to have my thumb right on this medial meniscus, and I'm going to twist internally rotate his tibia. What I'm going to do is make some broad strokes like this, okay? So this is called McMurray's test. If there was a positive, I'd let you know. And the positive can be at the medial joint line, or next I'm going to assess the lateral joint line, going this way. He had a clunk there at the lateral meniscus, a little click there at the lateral meniscus. But any pain with that? So I'm going to call that a negative McMurray's in the medial and lateral compartment. So that is the knee exam.